Thrombosis.TV coverage at the ISTH conference in Toronto. Joining us now, Dr. Andrew Cohen from Guy's and Thomas's Hospital, King's College in London. Thank you, sir, for coming by.
Pleasure.
We'll make it brief. We know you're a busy man leading up to this conference.
Thank you.
You've got several posters, and they're all related in a way. Can you just give us a background on what you're presenting?
Yeah. Well, three of my presentations are related to cancer and venous thrombosis, and they're ones perhaps we could talk about this morning.
Why is cancer-associated thrombosis so important in your opinion?
It's important because it's very frequent in patients with cancer. Sometimes the cancer precedes the thrombosis, sometimes the thrombosis precedes the cancer. So you have to think very carefully when you're managing patients with cancer, but you also have to think carefully when you're managing patients with thrombosis.
Which of the posters that you're presenting here at this conference do you think stands out the most, or is the most, I guess, important to you?
Well, there are two oral presentations, one on the incidence of venous thrombosis in cancer patients, another oral presentation on the recurrence of venous thrombosis in cancer patients, and then there's a poster presentation on mortality. And they're all from the same cohort. It's a cohort of 3.8 million patients in the UK that we've been following. We've found 35,000 patients have venous thrombosis. Within that 35,000 with venous thrombosis, we have 6,592 that have cancer-related thrombosis. Now those 6,592 cancer-related thrombosis come from a total population of 139,000 cancer patients within the 3.8 million total population. So it's a very large cohort, and what we've shown is that the rates of thrombosis in patients with cancer are very high, particularly those with active cancer. And we've concentrated on active cancer because active cancers are the ones where we can prevent the thrombosis, and that's what we aim to do. We aim to prevent it because it's better to give small doses of therapy to prevent a thrombosis than have to treat it later and have to use large doses of anticoagulants, which perhaps may cause bleeding in a group that are already at high risk of bleeding.
Dr. Cohen, given that background, what are the important findings of your data?
Well, our data on the incidence shows that in the active cancer period, the period 3 months either side of the diagnosis of cancer or 3 months after having any treatment for cancer like chemotherapy or radiotherapy or bone marrow transplantation, the risk of venous thrombosis is 54 times higher than in the normal population that's at risk of VTE. Our second finding is that the recurrence rates are twice as high, and our third finding is that the mortality is very high, with over 2/3 of the patients with active cancer dying in the first 12 months. And this is important because if we look in the first 3 months, and particularly the first month, we can see that much of that death is probably related to pulmonary embolism, and that we need to prevent these episodes occurring in the first place.
For doctors, what are some of the key takeaway points to remember in looking at cancer-associated thrombosis?
Well, the key points are that, first of all, it's not always easy to diagnose. Patients with cancer often have swelling of the legs or chest pain, and that can be related to the cancer or the thrombosis. And so you need to be vigilant, and you need to think of thrombosis as a cause of symptomatology. Second, that the diagnosis makes a difference because it affects the outcome for the patients. And thirdly, the treatments are different. At the moment, some of the best treatments for cancer-associated thrombosis are treatments like low molecular weight heparin, which have a very good effect on preventing recurrences and also not greatly increase the risk of bleeding. So the messages are suspect it, get the appropriate treatments, and then do something to prevent it recurring.
Very good. We'll leave it there. Thank you, Dr. Andrew, for joining us. We appreciate your time.
Pleasure. Thank you very much.
Okay.